our afternoon lunchtime plenary sessions. So this is where the rubber meets the road. We're going to hear about some of the results from the great work everyone's been doing. Our presenters today, let me just catch my breath. I got to everybody check your steps at the end of the day. Diane Hildebrand, a research associate from our team at UCLA's Integrated Substance Abuse Programs, and Rory Vanguard, a senior policy consultant at Aurora Health Group. Aurora, sorry. Diane Hildebrand works at UCLA as a research associate and data coordinator for the evaluation of California state opioid response. Okay, hold on. She currently holds a bachelor's in psychology from UCLA and plans to apply for a PhD in health psychology and health behavior research this fall. Research interests include the mind-body connection pathways, as well as using contemplative practices and psychedelic medicine to prevent and treat both mental and physical health conditions. As a Native American, it's important to her that her work and research are conducted through a health equity lens. And Rory Vanguard has a PhD and master's in public health. She's a senior policy consultant at Aurora Health Group. She supports clients at the state and county through project management, policy analysis, and program evaluation. Her background is in health disparities and policy. And prior to her work at Aurora, she worked at the Washington State University in Health Policy and Administration Department, focused on disability research, ranging from calculating policy impacts on total healthcare costs, out-of-pocket spending, access to healthcare, and disability-specific resources. And prior to that, she was at Oregon State University, again, focused on racial and ethnic variation and access to health insurance and healthcare before the Affordable Care Act implementation for young adults. In addition to research, Rory has taught a variety of public health and health policy courses for upper division graduates. We are delighted to have them share the results from what's been going on with Hub and Spoke, and I'm going to hand it over to you right now, Diane.
I think. All right. Okay. Hi, everyone. I hope you're enjoying lunch, and I hope you don't get too cold in here like I got earlier. So let's see here. We don't have anything to disclose today. And again, we just want to recognize that September is National Recovery Month, which is a great time for all of us to be meeting and discussing these important topics. And yeah. So there we go. All right, so hi everyone, I'm Diane Hildebrand. Today I'll be talking about the results from the California Hub and Spoke project from the implementation in 2017 up until today. I will start off talking a bit about the current state of the overdose crisis in California, since it has changed quite a bit since the start of this project and program began. I'll move into talking about what the Hub and Spoke system looks like and where we're making the biggest impacts in terms of expanding access to treatment. I'll also talk about some impacts on COVID-19 on our work and directions for moving forward into SOR3. And then I'll pass it to Rory, who will discuss some of the patient outcomes of treatment using GIPRA data. So here is a map of all drug-related overdose death rates by county in California. The darker the color, the higher the rate, and this is 2021 data. And in 2021, there was a total of 10,416 overdose deaths in California. And that is more deaths than any other state has reported. And this data is still preliminary, so it may increase even further than that. And what we're noticing now is that deaths aren't just concentrated in one area, it's statewide. And if you think back to when we started this hub and spoke program in 2017, the map didn't really look like this. This is what the map looked like in 2017. Yeah, so quite a change. And while the overdose crisis was impacting the entire state, it was a lot more concentrated in the rural northern counties of California and larger urban areas in Southern California, like San Francisco, Los Angeles, San Diego, were not nearly as high of death rates as they are now. So I'll jump back to the current map again, just to see the contrast here. So as you can see, some of the highest rates are still in the rural northern counties like Lake and Mendocino, but we're also now seeing very high rates in San Francisco, Inyo, San Luis Obispo, Kern. And this is not to say that the work we've been doing in these areas isn't making an impact, but it's just rather to frame where we've been and what's most important to respond to next, because we all know with the increasing presence of unregulated synthetic drugs like fentanyl, along with the COVID-19 pandemic, we're facing new challenges that we just did not anticipate 5 years ago when we started the Hub and Spoke project. So it's really more important now than ever to look at what is working, where, and for whom. So thinking about fentanyl, it's really important for us to look at not only how the overall overdose death rate has changed, but also which drugs are involved, because it's not just opioids anymore. So since Hub and Spoke began, which is that line in the middle of the graph here, that was the Hub and Spoke implementation in 2017, the all drug-related overdose death rate has more than doubled, from 11.6 deaths per 100,000 residents in 2017 to 25.2 in 2021. And when you look at the breakdown by drug type, you can see that the death rate for overdoses involving fentanyl has really skyrocketed in that time, which is the dark blue line on the bottom, from just 1.1 all the way up to 14.3, which is a huge jump in that amount of time. And because these illicitly manufactured synthetics have such unpredictable potencies when they're added to other unregulated drugs like heroin, counterfeit prescription pills, amphetamines, or cocaine, the overdose risk dramatically increases in all drug types. So here you can see how this impacts not only opioids, but also psychostimulants, which is the yellow line, which includes like methamphetamine as well. So, and of course, we do want to recognize that COVID had an effect on the rates of use as well, because there aren't really data to like tease that out in a graph like this right now, but we know that COVID really had an impact on stress and isolation, and it also affected access to treatment, which there were already disparities in, but those disparities have become even greater, and we'll take a look at that as well. So as of 2021, the all drug-related overdose death rate remains the highest among American Indian and Alaskan Native residents at 61.1 deaths per 100,000 residents. And their largest disparities are in opioids and psychostimulants, which is closely followed by Black or African American residents. And these two communities have about the same overdose rate with fentanyl, and Black and African American residents have a very high rate of cocaine related deaths compared to the other race and ethnicities. Rates have also been rising among Hispanic, Latinx, Asian Pacific Islanders, and whites as well, but the rates have increased the most rapidly for American Indian, Alaskan Natives, and Black and African American residents at 25.5% increase and 20.3% increase in just 1 year from 2020 to 2021. So we're seeing these very large and widening disparities in death rates, and the reasons are obviously very complex, but most relevant to our work on the California MAT expansion project are access issues. So our colleagues over at the California Bridge analyzed the California Overdose Dashboard data, which comes from Cures, and produced this really critical report showing that California zip codes with the highest proportion of people of color had the lowest rates of buprenorphine prescriptions per capita. And they found this to also be true still after controlling for income and controlling for rural urban status. So even though access to medications has been expanding in recent years, with there now being 183 opioid treatment program locations and 5,000 data, 2,000 waiver providers, where these findings are pretty concerning because it's showing that access to these medications is likely not expanding equitably. So when we think about the overdose death rates by race and ethnicity that we just looked at, it's important to consider how these gaps in access to treatment are contributing to these disparities. And as a part of the MAT expansion effort, what can we do moving forward to address those gaps while decreasing deaths overall? So the goal of the California Hub and Spoke system is to improve, expand, and increase access to MAT services across the state. So how can we respond to these current challenges like the impact of COVID, that we never would have predicted navigating 5 years ago when we started this work? To look at where we go next, it's really important that we understand where we've been and what we've accomplished so far. Okay, so I think it's a little cut off there, but there are currently 86 hub and spoke locations. 52 are health centers, which includes 34 FQHCs and 4 Indian health programs. 23 are OTPs, opioid treatment programs. The 6 others are SUD treatment settings, and the remaining 5 are behavioral health clinics, telehealth programs, and 1 pain clinic. 11 locations are in rural areas, and the remaining 75 are in urban areas. And there are also 71 locations now delivering telehealth services, which is a lot of growth compared to before the pandemic started, when we only had 30% of sites offering telehealth services. And now we're up to 82% of the sites offering telehealth services, which was kind of forced upon it, but I think it's really, really great for expanding access. So who are in these locations? Within these settings, as of June 2022, there were 461 MAT prescribers, meaning a provider with either a DATA 2000 waiver to prescribe buprenorphine or a provider working in an OTP setting that can prescribe methadone. And of those, 363 were actively prescribing MAT to patients, which is a big improvement from, that's about 79% of those who are able to prescribe are actually prescribing, which is a big improvement from earlier phases of the project where we were seeing about 60% consistently prescribing. So on average, this is about 4.3 prescribers per location, just an average, which is an increase of about 1 prescriber per location since SOR2 began in 2020, which is really good for sustainability because now locations aren't just relying on one person anymore to prescribe. And in most cases, well, there were 16 sites that had only one single provider, and in most cases, that was in a rural area where realistically it is harder to get more staff and get more prescribers and providers. 18 locations also had peer specialists, which equals to 28 peers among these locations, helping with patients in recovery for opioid or stimulant use disorders. And that is 7 new programs since SOR2 began that started employing peers. We also have 382 certified counselors, but unlike these other metrics, this number has gone down a little bit since 2020 when there was 392. So small decline, but this is probably an area where we're seeing the workforce challenges that the pandemic has brought on, and staff turnover and retention rates with staff. But overall, the hubs and spokes have been doing a great job of keeping their program staffed and continuing to prescribe despite all of these challenges. Oh, it's not. Shout out to you guys. Woo! Next, we'll go over some of the impacts of the program on services and numbers of new patients. So under SOR2, so just since October of 2020, there have been over 22,000 new patients starting MAT for opioid use disorder, over 11,000 new patients starting any treatment for stimulant use, over 5,000 receiving peer support, recovery services or coaching, and there were 5,593 overdose reversals reported to the sites. Woo, yes. And that's just what's reported. So you never know what they don't report following naloxone distribution efforts. So this is a huge impact, especially considering all the challenges that we have been facing in the past 2 years. So you guys should be proud. So here is the monthly data on new patients starting buprenorphine in the hubs and spokes, dating all the way back to 7 months before implementation of hub and spoke program back in 2017. And this is only for locations who have participated all the way through SOR2. So there was some sites that didn't go all the way through. So just keeping that in mind as well. But as you can see, over the first 2 to 3 years, buprenorphine prescribing increased a lot. Since that baseline period up to the end of 2019, there was a 219% increase in the number of new patients starting buprenorphine in the hubs and spokes. And then, of course, in 2020, when COVID hit, we saw the numbers drop quite a bit. But the good news is that there has been somewhat of a rebounding since then. In the most recent 7 months from today, we saw an average of 488 new patients per month getting started on buprenorphine, which is close to where we were at the end of 2019, when the number was averaging around 495. But it's important to recognize that things have been understandably somewhat unsteady since the pandemic began, and we all know that. We saw things start to build back up a little bit in 2021 and lost a bit of momentum last fall and winter again, but just seems to be correlating with those big COVID surges. We all know how that has impacted so many things. And we haven't quite gotten back to the rate of growth we were at before the pandemic. So looking at this simple trend forecast based on the rate of growth prior to February 2020, you can see the gray line in the middle there that represents the predicted number of new patients if COVID had never happened. And you can see that the 2 dotted lines above and below are the 95% confidence intervals, which is good to stay within. And we were still in the bottom of that 95% confidence interval of expected monthly growth up until about July of 2021. So really, according to this, the latest phase over the past year has been even more challenging than the spring of 2020. But I don't want this to overshadow the fact that we have still been starting a lot of new patients every month. And again, we're currently near the same level we were at the end of 2019. So I don't want us to lose sight of the fact that we've sustained quite a bit of our capacity in the face of all these barriers we're overcoming. But it is important to know and to recognize that we have shifted downward in the past year. So when we look at this density map of where new patients are starting treatment, we can see that there are large clusters of patients in larger urban areas like Los Angeles, San Diego, Sacramento area, also Santa Cruz. But there's also quite a bit going on in some of those rural areas, which if we look back on the overdose death rates, below this, you can see that those rural areas do have some of the higher rates, like Lake, Mendocino, Humboldt, Shasta, where a lot of the patients are coming in. And one region where numbers might be lower than anticipated is in the San Francisco Bay Area, which is a tiny little speck on this map. But we know San Francisco has some of the highest death rates in the state, especially among people of color. We do want to recognize, though, that there are a lot of other buprenorphine prescribers outside of the hub and spoke system in this area, which may be a part of what is happening here, but there's certainly also unmet need and treatment access gaps that could be an area of growth moving forward. So considering equity even further, when we look at patients who are starting treatment in hubs and spokes, we are continuing to see some of these racial and ethnic disparities that we discussed in the statewide data. So as of the most recent quarter, out of all new MAT patients across the hub and spoke system, about 63% were white, 16 about were Latinx, Hispanic, Chicanx, and only about 6% were Black or African American, and only about 4% were American Indian and Alaskan Native. So if we think back to that earlier graph of the overdose death rates by race and ethnicity, these lower numbers had the highest death rate numbers. So we're seeing some gaps between who is getting the treatment and who is being most impacted by the overdose crisis. Drilling down even further to a local level, when we compare the demographics reported by the hub and spoke system sites to the makeup of the counties in which they are located in, we see that many sites are underserving people of color, or POC. Of the 86 hub and spoke sites, 67% have had consistent disparities over time, meaning they are consistently serving a disproportionate percentage of white patients compared to the Native American, Alaskan Native patients, Black or African American, or Hispanic Latinx patients, even when overdose death rates in that county are highest among these communities of color. 17%, though, have been regularly representative of their county's populations, or at least serving a larger proportion of people of color. And 16% of the sites have been making improvements toward equity, which we consider to be a greater than 10% reduction in the number of new patients coming in that are white alone between year one, quarter one, and year two, year one, quarter one, and year two, quarter one. So this is definitely an area that we want to see improving quite a bit as we move forward into SOR 3. But it is promising that we have seen changes in 16% of the sites, so we know it's possible and improvements can keep being made, and that is equivalent to 13 sites who have been making improvements. So with all of this in mind, what are some of the next steps that we see for the hub and spoke system moving forward? Based on all this data and on some more qualitative evidence that we've collected over the past several years. So anecdotally, these are some strategies that we have heard during those quarterly learning collaboratives from the hub and spoke sites, some strategies that they're using to improve MAT access and address equity. So first is providing continual training to staff to reduce stigma, particularly stigma around people who use drugs that some care providers do still experience, but also training on the impacts of racism on health equity and training on cultural humility for providing relevant and respectful care to people of color, especially Black and Indigenous patients. We've also heard about efforts to keep all new staff trained on what the hub and spoke grant can provide. We've all seen the impacts of staff turnover over the past 2 years. And one thing that we have heard quite a bit is oh, I didn't know we could cover medication costs for uninsured patients, or I really wish we could provide transportation tokens to our patients living in rural areas. And these are both expenses that the grant covered. Well, I don't know. So a piece of the story of rebounding those new patient numbers and of ensuring that people who face the greatest barriers to treatment can get their medications is probably just continued awareness about what we can provide. Many folks have also discussed improving their outreach work, like becoming more active in local opioid coalitions, collaborating with new local harm reduction groups, things like that. But particularly, we've heard from a lot of folks that we need more outreach work in Spanish. We've heard this quite consistently over the past 5 years. In our 2020 provider survey, about 1/4 of the spokes said that their locations did not offer outreach or education materials in Spanish. And based on Learning Collaborative meetings, conversations during SOR2, this sounds like it is still a barrier for a lot of programs. But for other communities as well, not just Hispanic communities, it's really important to think about whether your materials and the outreach efforts that you're undertaking are both linguistically and culturally relevant. And once patients get to your program, that it is safe and welcoming for them, no matter what they look like or who they are. And then finally, we really want to be meeting patients and people where they're at. So showing up to where we know folks who can't reach our services might already be with things like a mobile unit, also improving the use of telehealth services, because while most sites are providing telehealth services, like I mentioned earlier, there are still 15 that are not. And on top of that, there are still barriers to equitable access to the internet itself. So even being able to use telehealth. So thinking about that, along with mobile units and mobile services, can we offer things like hotspots? What sorts of connections can we make to telehealth providers in our area? So continuing to learn from each other about what is working, where, how, for who, and making sure we're monitoring access and equity by using those quarterly data reports that we all get before Learning Collaboratives can make big impacts here. Just making sure you're aware of where your program's at and seeing if you can make improvements and continuing to monitoring those can be really helpful. So as we move forward into SOR3, it's important to remember the wonderful impacts we're all making on the lives of so many across the state. Over 22,000 patients started treatment in the past 2 years, and that is really no small feat. I hope we also can keep in mind the resources and the connections that we all have to each other in rooms like this one and to people online. We've heard so many creative strategies for continuing improving access to treatment, and some of the most informative data we have comes from all the lessons that we have shared in Learning Collaboratives and collaborating in rooms like this one. So it's really important to keep that in mind and collaborate and use each other for help. Thank you. Rory's up next.
Good afternoon. All right, my name is Rory Vanguard. I'm with Aurora Health Group. I'm talking about everyone's favorite topic today, the GIPRA surveys. That's right. So we did a brief little data analysis on the GIPRA surveys, and then I'll move over and we'll talk more about some of the upcoming changes of the GIPRA surveys that SAMHSA is reissuing a new survey. So we'll go over some of that. Again, very exciting. So the data analysis that we went through looked at all of the GIPRA surveys from October 1st, so the very beginning of SOR2, until July 19th, just so I had some time to, actually finish the analysis before presenting. So we'll go through the initial, just who is in the sample and what it looks like. So first, we only looked at the intake survey. So everyone that had any intake, if they had multiple episodes of care, we just looked at the most recent intake survey. We removed all of the duplicates. And then we did our initial comparison to look, are there any differences between hubs versus spokes? Who are we seeing at sites? So first of all is overview of participants. We're seeing approximately 70% of participants in the GIPRA surveys we're seeing at spokes, and approximately 30% were at hubs. So our initial sample of intakes only are almost 8,000 participants. So then we look to see what age are participants. And again, are there any differences between hubs versus spokes? Spoiler alert, as you can see, no significant large differences in ages between hubs versus spokes. Other than in the over 65 plus group, we did see that hubs see slightly more. But generally, the most prevalent age group is age 25 to 34, followed by 35 to 44, 45 to 54, 55 to 64, 18 to 24, and then 65 and over. And I don't need to linger too long in this slide because Diane already discussed the race and ethnicity of clients being seen at sites. We have just over 80% of clients identify as white, and this is very similar between both hub and spoke sites. One thing to note with this graph is that the Hispanic Latino category is a separate question, so it's not included in the adding to 100% of the race categories. So we're seeing a big disparity in the overdose data that was just presented by race and ethnicity and who is successfully accessing treatment, at least as far as who is being given a GIPRA survey. This is a question that we hear a lot of sites say is really difficult to administer to clients, especially upon intake. I've got some good news coming for you on that one. But we looked at this one by gender rather than hub versus spoke because it was incredibly similar. So looking at male, female, transgender, and other, and we're seeing a very high proportion saying, yes, I have been exposed to trauma or violence at some point in their life. Now, there's no perfect one-to-one question to the general, US experience of trauma, but these are higher than we see for other trauma questions in other national surveys. So definitely a higher proportion of individuals reporting trauma. So for the second portion, we went on ahead and we matched the data for those who had an intake to those who had a 6-month follow-up survey. So clients who had either an administrative follow-up or no follow-up whatsoever were excluded here. And we'll talk a little bit about who we're missing, but basically the implication is that we're essentially highlighting participants that remain in contact with sites, and we kind of make the assumption that that means that they were remaining in treatment and are potentially having more of the success stories. So what we're losing is really valuable information on clients who either lost contact or didn't remain in treatment. Nearly 60% of our overall sample was lost. And again, part of this could also be that the client had an intake, maybe 3 months before I pulled data and they just haven't gotten to their 6-month survey. So it's not exact science because it's working with people. But we dropped from about 8,000 participants to just over 3,000 participants, or 43% of the initial sample. So just a quick overview of the differences, basically who was lost to follow-up. 46% of the respondents that were lost to follow-up reported 20 to 30 days of drug use in the last month at their intake survey, whereas this was about 37% of those that remained in treatment and had a 6-month follow-up. 20% of respondents without a follow-up survey reported being unhoused, and then this compares to 11.5% of our match sample. We didn't see any major changes between males and females. But of the entire, 6,000, 8,000 sample, we only had 18 individuals that identified as transgender, and only one had a follow-up survey. We had 6 participants who selected other for gender, and they only had 3 that had follow-up surveys. We didn't see any major loss to follow-up between a hub versus a spoke, no variation in race and ethnicity, and no variation in age. So we're going to start out looking at changes in housing status over time. This is just a basic, are you housed, yes, no, and then we'll break into the split of how individuals are housed. So we're seeing a change. The bottom darker line is the intake survey, and then the top lighter line is at 6 months. We're seeing a decrease in individuals responding that they were unhoused and an increase in responding that yes, they were housed. So now we'll look at how. Again, the bottom dark colored bar is the intake. The top lighter colored is at the 6 month survey. We're seeing decrease in just other, decrease in residential treatment, no changes in halfway house, a decrease in time from living in someone else's apartment, room, or house. And then this is what I think is really cool and super positive. We're seeing an increase of individuals saying that they now have their own house, apartment, room. They're not staying with someone else's. Yes, fantastic. Totally agree. And when we talk about, security and stability and, basic food, water, shelter, these are really important things. Another super positive outcome is a change in employment status over time. As we change from the intake survey to the 6 month follow-up survey, we're seeing a decrease in individuals reporting that they are unemployed and not looking for work. No real change in being unemployed and disabled, which we wouldn't expect. We see a decrease in people saying that they're unemployed and looking for work. And this is, again, the really positive, just like the housing. We are seeing a huge change in individuals saying that they are now employed either full-time or part-time. This is only 6 months in. Yes. So positive, so wonderful. I don't have to preach to the choir about how important this is. Another really great slide, looking at the number of days using drugs over time, we went on ahead and we categorized this to just the most popular, kind of where we saw spikes in numbers. So looking at the intake data versus the 6 month follow-up, huge decreases in individuals saying that I have used substances in 20 to 30 days in the last 30 days. We're seeing decreases in 10 to 19 days, 4 to 9. Now, one of the things that's kind of a downfall here is we can't track how many individuals went from 20 to 30 to 4 to 9 versus 20, 30 to 0. But we can see these overall trends that we are decreasing in days of drug use, and then this huge increase in individuals reporting 0. In the last 30 days, I have used 0 drugs. So, yes. I've heard that a lot of sites are curious about alcohol use, and because, state opioid response dollars are not really aimed at alcohol use, we thought that we'd go ahead and share. So we're seeing, again, we don't have as huge of a population reporting 20 or 30 days of alcohol use as we did with drugs, but we still see that decrease in going from 20 or 30 days on down, and we still see an increase in going to 0 days of alcohol use. Again, this is only 6 months time. It's a very short time frame. Yes, yes. This is the question that asks, in the last 30 days, have you been hit, kicked, slapped, or otherwise physically harmed? I'm pleased that these numbers are not, starting higher. but we're still seeing decreases. Whether this has to do with moving out of someone else's house, room, apartment and into your own, whether it has to do with becoming employed, whether it has to do with not using drugs, which came first, the chicken or the egg. These are all intercorrelated outcomes. They're all incredibly positive. We see the same thing with social connectedness over time, where they ask if you've attended any family, voluntary, religious, or just had other interactions. This is basically getting at, do you have a social support network? And we're seeing an increase in people saying, yes, I am building these supports, I am building these relationships. Having support in recovery, again, I don't have to preach to the choir about how important that is. And then this is kind of an overall how everything wraps up. How would you rate your quality of life? And we're seeing people going from saying, well, it's poor or fair, and then 6 months down the road saying, it's good, it's very good, it's excellent. Again, all of these really positive movements in a very short time span, especially when we think about how long a time span of recovery is. Very significant outcomes. So overall, we have these really positive outcomes of the impacts of hub and spoke sites. Areas to improve is just our retention, to having that follow-up survey, because we did lose a lot of data. And then the disparity in race and ethnicity of clients as compared to overdose data. There is potential for bias in the data. For those of you that were around for the beginning of SOR2, you'll remember that you were asked to redo the intake GIPRA survey on clients. So we don't necessarily have true baseline data. We can have some intakes that were already, a year down the road and having these great outcomes. So there is potential that our outcomes are even more positive than demonstrated just due to that. Let's see. And then again, who we lost. So now the exciting part, the new GIPRA survey that will be introduced for SOR3. And I'm so glad to hear that with Kathleen's announcement this morning that there will be kind of some bridge funding. So this will in fact impact all of you. So as you know, SOR2 ends at the end of the month. We encourage you to please make sure that you are inputting all of your surveys from this time period by that date. Unfortunately, this slide is a little bit outdated. Just last week, SAMHSA gave us some new guidance, and we'll be sending this around as written guidance, so please disregard the slide. The new survey will actually be enacted on December 10th. I know, what a wonderful date. They are saying that you can use the current GIPRA survey until December 9th, and then starting December 10th will be the new survey. And then they're giving sites until January 2nd to input anything from December 9th and before. So it's not quite as stringent. We'll still be using REDCap. We don't anticipate any sort of major changes there. The process should just be the same. What we're doing on the back end is just updating the survey questions. Removed 40 questions, replaced it with 41. As you know, a question can be part A, B, C, D, E. So some of the overview of things that changes, gender now has additional categories, race and ethnicity has additional categories. Education is no longer selecting, first grade, second grade, third grade. It's just less than high school, some college, college and professional. They're no longer asking if someone's uncle, grandfather, or parent had military service and details about that. SAMHSA now only cares about if the client had service. And now they're asking if you have enough money for a specific thing. Do you have enough money for rent? Do you have enough money for food? Do you have enough money for utilities? Rather than just the general, do you have enough money? And then it's moving to income categories. Questions that are leaving GIPRA, this is going to be a popular one. Number one, experience of trauma and violence. That one is going away. I'm not sure who notified SAMHSA that that was a difficult question. It was you. Well, thank you. Many sites, thank you. Personally, from a data perspective, I'm a little bit sad to see it go because I use that, but from a human perspective, it sounds like it's a positive. Income is no longer asking about sources of incomes. It's just an annual pick a category. And then again, familial military service. The new questions that are being added, and this is my last slide, they're asking about vaccination status if the client has had their COVID vaccine or hepatitis A and B. They're asking questions about, are you referring clients to HIV services or hepatitis B and C services? Questions about health insurance and applications for either insurance or public assistance programs. Are you helping clients get TANF or SNAP benefits if they qualify? They're going to ask some questions about barriers to access to care. So what does your travel time look like? Again, these will be categories to select. If they're living with someone who regularly uses substances, and where they've recently received medical care from, so we know do they need some catch-up care? Are they, linked to primary care? Are they using the ED? And then finally, in the 6-month and the discharge surveys, they're basically asking some outcome questions. Were you able to be reunified with your children? What were your achievements and results of treatment? Has technology supported your recovery? So basically having, kind of a client satisfaction survey. Did we get you where you wanted to go? So at this point, I'm going to go ahead and open it up to questions for either Diane or myself. And we thank you so much for your time.
Questions? Oh.
Hello? Okay, just checking. So how long is the Gipper survey going to be? Still going to be like 25 pages or is it going to be a little lesser?
That is $1 million question. I saw an email this morning that said that SAMHSA had just posted it on the CSAT webpage. So I'm not totally sure yet. They gave us kind of a preliminary, this is what we think it's going to be, and then they got some feedback and they changed some things. So TBD on that, but we will have a lot of guidance for it.
Something here from our online participant?
Thank you. This is for you, Diane. Does the growth curve plateauing out relate to capacity of programs, or is it more related to service saturation of service for clients accepting services?
Wait, sorry.
Is it related to capacity of the programs or saturation of services, the plateauing of the curve?
Oh, okay, sorry. It's just like hard to hear you when the mic's going this way. Say it one more time, the full question.
Does the growth curve plateauing out relate to capacity of programs or related to service saturation of service for clients accepting services?
Okay. I don't totally know. I'm more of just, I get the data and I see it, but I assume the plateauing has to do a lot with COVID, access treatment issues, also on from the patient perspective, getting to treatment and access issues, but also from the site's perspective on staff turnover and being able to maintain those connections with clients when there is so much staff turnover in the past 2 years. But I don't totally know all the reasonings behind it, but those are some things like I've heard over the years.
Hello. No? Yes? Cool. Okay. Do you know if a deep dive has been explored related to deaths and whether there's an association with ever being part of one of the programs? Does that make sense?
Sorry, say it one more time. The deaths.
So the over 10,000 deaths
Mhm.
related to opioid overdoses. Do you know if a deep dive has been done, for example, just a cures report of those 10,000 folks, were they ever prescribed buprenorphine?
Oh, That's a good question. I know they have data on the type of drugs that the death was caused by, but I'm not sure if there is the connect between the individual who passed away and if they had treatment or not. Off the top of my head, I don't think so, but that is a good question. And